Here's something that might actually surprise you. Estimates suggest around 1 in 26 people in the U.S. will experience epilepsy sometime in their life.
Wow, 1 in 26, that's quite common, really. Much more than most people probably think.
Exactly. And it really highlights why, getting a solid understanding of what epilepsy is and how it works can be so relevant for all of us.
Absolutely. And when we talk about epilepsy, it's not just one single thing, right? It's a neurological condition defined by this tendency for recurring seizures. And the way doctors classify and diagnose it has actually changed quite a bit over time.
Which is exactly what we're diving into today. We're looking at how seizures and epilepsy are actually classified and diagnosed now.
Right, using the current approaches.
Yeah, and we've got a fantastic guide for this deep dive. It's a review article called Classification and Diagnosis of Epilepsy from the journal Continuum, published just this year.
A very up-to-date source, then.
Definitely. So for you listening, think of this as like your pathway to really getting a clear, structured handle on what can seem like a pretty complex topic. We want to cut through the noise and pull out those key aha moments about how the experts approach it.
Yeah, basically unpack the system they use. Our mission here is to look at the current classification, the diagnosis methods, highlight those key distinctions they make, and really explain the why behind it, all the reasoning for this systematic approach.
Okay, great. So let's jump right in. What is epilepsy, fundamentally? You mentioned the definition has changed.
It has, yeah. If you go back to 2005, the International League Against Epilepsy, or ILAE, their definition focused on having a brain disorder with this lasting predisposition to generate seizures.
Okay, predisposition, so like a tendency.
Right, and practically that often meant someone had experienced at least 2 unprovoked seizures happening more than 24 hours apart.
So meaning more than one event, basically.
Yeah, initially, yes. But then in 2014, they brought out a new practical definition, which, well, it expanded things a bit. It kept the 2 unprovoked seizures more than 24 hours apart,
Okay.
but it added 2 other ways to meet the definition. One was having just 1 unprovoked seizure, but only if the person also had a high risk of having another one.
High risk. How high are we talking?
They put a number on it, at least a 60% chance of recurrence over the next 10 years.
Wow, okay. That's quite specific.
Yeah.
So you wouldn't necessarily have to wait for a second seizure if the risk was clearly high.
Exactly. It allowed for, potentially earlier diagnosis and intervention for those high-risk people. The idea was maybe preventing future seizures.
Makes sense. And the third way?
The third way was simply being diagnosed with a recognized epilepsy syndrome. Some syndromes are just defined as epilepsy from the start.
Got it. So multiple seizures or one seizure plus high risk or a specific syndrome.
That's the 2014 definition in a nutshell.
Now, what if someone has epilepsy, but then they stop having seizures for a long time? Is it still considered active?
That's a good question. There's this concept called resolved epilepsy. It basically applies if someone's been seizure-free for 10 years and they've been off all anti-seizure medication for at least the last 5 of those years.
10 years seizure-free, 5 off meds.
Or it can also apply if someone had a specific childhood epilepsy syndrome that they've clearly outgrown, one known to be age-related.
Interesting. So it's not always a lifelong diagnosis then,
Not necessarily, no.
which is encouraging.
Now, the article mentions the classifications themselves have evolved, too. Can you give us a quick sense of that history?
Sure. I mean, people have been trying to categorize seizures for a while. Gastow did some important early work back in the late 60s, early 70s. Then as EEG technology got better,
The brainwave measuring thing.
right, electroencephalography, the ILAE came out with its first official seizure classification in 1981, and then one for the epilepsies themselves in 85.
And these have been tweaked and revised over the years. New syndromes were discovered, terminology needed refining. There was even a proposal for like a 4-dimensional system trying to integrate symptoms, brain location, cause, and other medical issues.
Sounds complicated.
It was ambitious, but the point is, it's been this ongoing process of trying to make the categories better, more useful, more accurate as our understanding grows.
Which brings us to the current system, the 2017 ILAE classification. That's the one we're focusing on. It uses 3 tiers, right?
That's the one. 3 main levels or tiers to the classification.
Okay, let's break those down. What's tier 1?
Tier 1 is all about the seizure type. Basically, what kind of seizure is it? Does it start in one specific area of the brain? That's a focal onset.
Okay, starting in one spot.
Or does it seem to involve networks on both sides of the brain right from the beginning? That's generalized onset.
Starting everywhere at once, kinda?
Pretty much, yeah, involving both hemispheres simultaneously. And then sometimes you just don't have enough information to tell how it started. That's called unknown onset.
Focal, generalized, or unknown. Got it. That's tier 1. What's tier 2?
Tier 2 is the epilepsy type. This looks at the bigger picture. Based on the types of seizures someone has, plus other info like EEG results or brain scans, we classify the epilepsy itself as either focal epilepsy, generalized epilepsy, or combined generalized and focal epilepsy.
Combined, meaning they have both types.
Exactly. They experience both focal onset and generalized onset seizures. And again, if there isn't enough information to categorize the overall epilepsy type, it's called unknown epilepsy.
Okay, so seizure type first, then epilepsy type. What's the third tier?
Tier 3 is the epilepsy syndrome. This is where we see if the person's specific cluster of features, like their seizure types, their age when it started, their EEG patterns, maybe even the cause fits a recognized pattern, a known syndrome.
Like a specific named condition within epilepsy.
Precisely. And identifying a syndrome can be really helpful for predicting prognosis and guiding treatment, but not everyone with epilepsy fits neatly into a defined syndrome.
Right. And you mentioned cause, etiology, and other health issues, comorbidities. Where do they fit in?
They're super important and are considered at all levels. What's causing the epilepsy and what other conditions the person has are woven into the whole picture, from understanding the seizure type right through to syndrome identification.
Okay, that framework makes sense. Seizure type, epilepsy type, syndrome, with cause and comorbidities considered throughout. Let's go back to tier 1, the seizure types. You said focal onset starts in one area. What else do we need to know about those?
Well, a key distinction within focal seizures is based on awareness during the seizure.
Why?
Is the person aware of themselves and their surroundings while it's happening? If yes, it's a focal aware seizure. If their awareness is altered or affected at any point during the seizure, even briefly, it's a focal impaired awareness seizure.
So it's about their consciousness during the event, not whether they remember it after.
Exactly. That's a crucial point. Memory afterwards can be affected in either type, but it's the awareness during the seizure that classifies it.
Got it. And I saw a term, focal to bilateral tonic-clonic. What's that?
Ah, yes. That describes a seizure that starts focally in one area,
Okay.
but then it spreads rapidly to involve both sides of the brain, leading to a generalized tonic-clonic seizure. You know, the kind people might think of as a grand mal seizure with stiffening, then jerking.
Right. So it starts small, then goes big.
Essentially, yes. The name tells you the progression.
Now, focal seizures can have motor symptoms, movements, or non-motor symptoms. Let's talk motor first. What kind of things might you see?
There's quite a variety. You can have automatisms, which are these sort of repetitive, automatic-like behaviors, things like lip smacking, chewing motions, fiddling with clothes, maybe tapping their hands, sometimes even simple words or phrases repeated.
Stuff they aren't really aware they're doing.
Usually, yes. Then there are epileptic spasms, sudden brief flexions or extensions. Atonic seizures involve a sudden loss of muscle tone, so someone might just go limp or fall. Clonic seizures are rhythmic jerking movements. Hyperkinetic involves more wild or agitated movements like thrashing or bicycling legs. Myoclonic are these very brief, sudden, shock-like jerks of a muscle or group of muscles. And tonic seizures are about sustained muscle stiffening or tensing.
Wow, that's a lot of different ways the body can move during a focal seizure.
Yeah.
What about the non-motor side? What happens there?
Non-motor symptoms can be just as varied and sometimes a bit harder to spot. You might see autonomic changes, heart rate speeding up or slowing down, changes in breathing, sweating, maybe goosebumps, or feeling nauseous.
Okay, body function changes.
Right. There can be behavioral arrests where the person just suddenly stops what they're doing, like they're frozen mid-action. Then cognitive symptoms, feelings of déjà vu, like you've lived this exact moment before, or jamais vu, where familiar things seem suddenly strange or unreal. Difficulty speaking or understanding language during the seizure, that's ictal aphasia.
Déjà vu can be a seizure symptom. Interesting.
Yeah, it can, yeah. Also, emotional symptoms, sudden, unprovoked feelings of fear, anxiety, sometimes even joy or pleasure. And finally, sensory symptoms. This could be tingling, numbness, seeing flashing lights or shapes, hearing buzzing or ringing sounds, experiencing unusual tastes or smells.
Those sensory ones. Is
Yeah.
that what people call an aura?
Often, yes.
Mm.
Especially if it happens right at the start of the seizure before other symptoms. That sensory experience can act as a warning sign. It's actually part of the seizure itself, originating focally.
And the article mentioned that the very first symptoms someone notices can be really important for diagnosis.
Absolutely crucial, because that first sign or symptom often gives the best clue about where in the brain the seizure is starting, the epileptogenic zone.
So it helps pinpoint the origin.
Exactly. For example, there's something called a Jacksonian march. That's where, say, jerking starts in a finger, then spreads up the arm, maybe to the face, all on one side. That pattern strongly suggests the seizure started in a specific part of the motor cortex on the opposite side of the brain.
Fascinating how the symptoms map to the brain like that.
Okay, that covers focal onset well. Let's switch to generalized onset seizures, the ones involving both sides from the start. What are the motor types here?
Well, the most widely known is the tonic-clonic seizure. We mentioned the
Mhm.
stiffening, then jerking. But you can also have just clonic seizures, rhythmic jerking without the initial stiffening, or just tonic seizures, sustained stiffening alone.
Okay.
There are also myoclonic seizures, those brief shock-like jerks happening on both sides of the body. Atonic seizures with sudden loss of muscle tone leading to a collapse or head drop, sometimes called drop attacks. And you can get combinations too, like myoclonic, tonic-clonic, or myoclonic atonic.
Lots of variations there, too.
And epileptic spasms can also be generalized, appearing as sudden symmetrical body contractions.
What about non-motor generalized seizures? That's mainly absent seizures, right?
Primarily, yes. Absent seizures are characterized by that sudden, brief impairment of consciousness.
Hmm.
But there are subtypes here too.
Typical absent seizures are the classic blank stare, maybe lasting just a few seconds, with very abrupt start and finish. The person just pauses, then resumes what they were doing, often unaware it happened. Sometimes there are subtle motor signs like rapid blinking, eyelid fluttering, or maybe slight mouth movements.
Just zoning out briefly.
Kinda, yeah.
Hmm.
Then there are atypical absent seizures. These tend to start and end more gradually, might last longer, and often have more noticeable changes in muscle tone, maybe some slumping or slight jerking. They're often seen in people with more severe epilepsies.
Okay, typical versus atypical.
Yep.
Any others?
Yes, myoclonic absent seizures involve clear muscle jerks, usually in the arms or shoulders, occurring along with the absence, and eyelid myoclonia, which is characterized by rapid fluttering or jerking of the eyelids, often with the eyes rolling upwards. This is sometimes seen with brief absences, particularly in a specific syndrome called Jevons syndrome.
Right. Lots of detail within absence.
Yeah.
Now, what about that third category in Tier 1? Unknown onset.
That's basically used when you just don't have enough information to say for sure if it started focally or generalized. Maybe the beginning wasn't witnessed or the description is unclear.
So you classify what you do see.
Exactly. So you might classify it as a tonic-clonic seizure of unknown onset, or maybe epileptic spasms of unknown onset, or behavioral arrest of unknown onset.
Yeah.
If there's
So give me an example. If someone mostly has, say, typical absent seizures, and their EEG shows that classic generalized spike and wave pattern.
then that strongly points towards generalized epilepsy.
Okay. And if someone has focal impaired awareness seizures, maybe their EEG shows abnormal spikes coming from their temporal lobe, and their MRI shows a small scar in that same area.
That would clearly fit with focal epilepsy. The evidence lines up pointing to a specific starting point.
And the combined type.
That's for individuals who clearly have evidence of both types. Maybe they have focal seizures sometimes, generalized tonic-clonic seizures other times, and their EEG might show both focal abnormalities and generalized patterns. Some specific syndromes, like Dravet syndrome or Lennox-Gastaut syndrome, often fall into this category.
And unknown epilepsy type.
That's reserved for when, even after investigation, there isn't enough information to confidently assign one of the other types. Maybe they've only had seizures of unknown onset and their EEG is normal, for instance.
Got it. It's about integrating all the available evidence. Now, Tier 3. Epilepsy syndrome. You said this is about recognizing specific patterns.
Exactly. An epilepsy syndrome is like a distinct condition defined by a whole cluster of features, typical seizure types, a usual age when it starts, characteristic EEG findings, maybe associated developmental issues, often specific causes, and usually a somewhat predictable course or prognosis.
So identifying the syndrome tells you a lot more.
It really does. It can significantly influence treatment choices. Some medications work better for certain syndromes, and it helps give families a better idea of what to expect long term. Many syndromes are age-dependent, typically starting in infancy, childhood, adolescence, or sometimes later.
The article groups some examples. Let's talk about genetic generalized epilepsies. What falls under that?
This is a large group. formerly often called idiopathic generalized epilepsies. It includes 4 well-defined syndromes. First, childhood absence epilepsy starts in kids, lots of typical absence seizures. Second, juvenile absence epilepsy starts a bit later, maybe in teens. Absences might be less frequent, but they often also have myoclonic jerks or generalized tonic-clonic seizures.
Right.
Third, juvenile myoclonic epilepsy, or JME. Also starts in adolescence typically. Hallmark is those morning myoclonic jerks, often triggered by lack of sleep. They usually have generalized tonic-clonic seizures too, and sometimes absent
Oh,
seizures.
morning jerks, okay.
And fourth, epilepsy with generalized tonic-clonic seizures alone. Pretty self-explanatory. The main or only seizure type is generalized tonic-clonic. Now, if someone has generalized seizure types, like absence myoclonic, tonic-clonic, and their EEG shows generalized spike wave activity,
That typical pattern.
right, usually between 2.5 and 5.5 hertz, but they don't quite fit one of those 4 specific syndromes, they'd still fall into the broader category of genetic generalized epilepsy.
Okay, that makes sense. What about the focal self-limited epilepsies of childhood? That name sounds promising.
It often is. These are focal epilepsies starting in childhood that importantly have a very high chance of resolving completely, usually without any lasting neurological problems.
That's great news for families.
Definitely. There are a couple of main subgroups here based on just how likely remission is. One group has a really high likelihood of full remission. That includes self-limited epilepsy with centrotemporal spikes, often called Rolandic epilepsy, think focal seizures affecting the face or throat, often at night,
Okay.
and self-limited epilepsy with autonomic seizures, which used to be called Panayotopoulos syndrome, features often prolonged seizures with prominent autonomic symptoms like vomiting or pallor.
Right, so those usually resolve. What's the other subgroup?
The other subgroup also has a high likelihood of remission, but for some kids, seizures might continue into adolescence or even a bit beyond. This includes things like childhood occipital visual epilepsy, gastote type, which involves visual symptoms, and photosensitive occipital lobe epilepsy. Still a generally good outlook, but maybe not quite as certain to stop in childhood.
Good to know those distinctions. The article also mentions developmental and epileptic encephalopathies. That sounds more serious.
It generally is, yes. This term applies to severe epilepsy conditions, where the frequent seizure activity itself or the underlying cause is thought to contribute negatively to brain development and function, often leading to cognitive and behavioral impairments beyond what you'd expect from the underlying cause alone.
So the epilepsy itself impacts development.
That's the idea. Examples include Dravet syndrome, which often starts in infancy with prolonged seizures triggered by fever and leads to multiple seizure types and developmental slowing. Epilepsy with myoclonic atonic seizures or Deuce syndrome. Lennox-Gastaut syndrome, LGS, characterized by multiple seizure types including tonic and atonic seizures, a specific slow spike wave EEG pattern, and intellectual disability. And Rasmussen syndrome, a rare inflammatory condition usually affecting one brain hemisphere, causing intractable seizures and progressive neurological decline on one side of the body.
Okay, those are definitely complex and challenging conditions. So identifying the syndrome in Tier 3 really refines the picture.
Absolutely. It adds a whole layer of prognostic and therapeutic information.
Now, woven through all of this is etiology, the cause. The article lays out 6 main categories.
That's right. The 2017 ILAE classification uses 6 broad etiological groups: structural, genetic, infectious, metabolic, immunologic, and idiopathic, which basically means the cause is unknown. And importantly, sometimes more than one category can apply to the same person.
Okay, let's quickly touch on each. Structural.
Structural means there's a physical abnormality in the brain, usually seen on an MRI scan, ideally one done with an epilepsy protocol for best detail that's thought to be causing the seizures.
Like what kind of abnormalities?
In kids, it could be a malformation of brain development, or maybe damage from around the time of birth. In adults, common causes are things like stroke, brain tumors, head trauma, scarring from past infections, or vascular malformations. In older adults, cerebrovascular disease and neurodegenerative conditions like Alzheimer's become more common structural causes.
Makes sense. Genetic.
This is when a specific change in a gene is identified that's known to cause epilepsy or be strongly associated with it. Like the SCN1A gene mutation, often found in Dravet syndrome, it doesn't always mean it's inherited, though many are new de novo mutations.
Right, not always hereditary. Infectious.
Infections are a major cause worldwide. You can have seizures during an acute infection like encephalitis or meningitis.
Acute symptomatic seizures.
Exactly. But infections can also cause lasting brain injury or inflammation that leads to chronic epilepsy developing later. Think of things like viral encephalitis, neurocystis cercosis, parasitic brain infection, even malaria can increase risk. This refers to underlying disorders of the body's chemistry where seizures are a key symptom. Often these are genetic too, involving problems with how the body processes amino acids, or issues with mitochondria, the energy factories in cells, or problems with how sugars are attached to proteins, glycosylation disorders, or lysosomal storage diseases. These are really important to identify, especially in kids, as sometimes treating the metabolic disorder itself can help the seizures.
Okay. Immunologic. This seems like a newer area of focus.
It is increasingly recognized. This is where the body's own immune system mistakenly attacks parts of the brain, causing inflammation and seizures. We now know about several specific antibodies involved, like antibodies against the NMDA receptor, or GAD65, or LGI1 proteins.
And finding these is important.
Very important, because these epilepsies often respond well to immunotherapy treatments that target the immune system. And finding certain antibodies, like NMDA receptor antibodies, might also prompt a search for an underlying tumor that could be triggering the immune reaction.
Wow, okay. And finally, idiopathic.
Idiopathic just means that despite a thorough evaluation, we haven't identified a specific structural, genetic, infectious, metabolic, or immunologic cause. It accounts for maybe a third of epilepsy cases. It doesn't mean there is no cause, just that we can't find it with current tools or knowledge.
So our understanding and diagnostics are still evolving. Given this detailed 2017 classification, what does the article say are its main strengths and weaknesses?
Well, on the plus side, formally including unknown-onset is seen as helpful and practical. The system is generally considered relatively user-friendly in different settings. Making a clear distinction between focal and generalized epileptic spasms was an improvement. And it encourages using more detailed descriptions of what seizures look like, the semiology.
Okay, those sound like good steps. Any downsides or limitations mentioned?
Some feel it wasn't a huge leap forward from previous versions. There's criticism that it still doesn't provide enough detailed semiology guidance to really pinpoint seizure origin accurately just based on description. It also maybe doesn't focus enough on auras or how seizures evolve over time, and sometimes it needs adapting for specific uses like clinical trials. Plus, seizure type classification isn't solely based on what you see. EEG findings play a role too.
So, useful, but still room for refinement as we learn more.
Exactly. It's a framework in progress, really.
All right. So putting this all together, how does a doctor actually approach diagnosing someone who comes in with suspected seizures? What's the process?
It really starts with a super detailed clinical assessment, listening carefully to the story. What might have triggered the event? Were there any warning signs or an aura? What exactly happened during the event? Getting descriptions from the patient and any witnesses is key here. And what was the recovery like afterwards?
Getting the full picture of the event.
Absolutely. A crucial early step is to figure out if it could have been a provoked seizure caused by something immediate like alcohol withdrawal, a severe metabolic imbalance, maybe a very high fever. Those don't necessarily mean the person has epilepsy.
Okay, rule out temporary triggers first.
Right. Then determine if the event really was an epileptic seizure and if there's a history suggesting epilepsy, like similar past events.
Yeah.
You also need to consider risk factors. Did they have a significant head injury, meningitis, or encephalitis, a stroke? Complex febrile seizures as a child. Is there a family history of epilepsy?
Checking for things that make epilepsy more likely.
Exactly. And a huge part of diagnosis is considering other things that can look like seizures but aren't the differential diagnosis.
What kind of things mimic seizures?
Oh, several things. Fainting spells or syncope. Psychogenic non-epileptic events which look like seizures but stem from psychological pauses. Certain movement disorders. Migraines, especially complex ones with aura, and some sleep disorders like narcolepsy or REM sleep behavior disorder. Distinguishing these is critical.
Right, because the treatment would be totally different. What about tests like EEG and brain scans? How do they fit in?
They're very important supporting tools. EEG, the brainwave test, is fundamental. It can help confirm a diagnosis, help differentiate between focal and generalized onset.
Like we talked about for Tier 2.
Exactly. And specific EEG patterns can point towards certain epilepsy syndromes. But, and this is key, the EEG supports the diagnosis. It doesn't make it on its own. Epilepsy is a clinical diagnosis based on the history and events. You can have epilepsy with a normal EEG between seizures.
Okay, so EEG is helpful but not definitive alone. What if it's unclear?
If a routine EEG doesn't give clear answers, sometimes prolonged video EEG monitoring is done. That means recording EEG and video simultaneously, often for days, hoping to capture an actual event to analyze the brain activity during it. Even home videos taken by family can be surprisingly useful sometimes.
And neuroimaging, MRI, CT scans.
Neuroimaging is generally recommended for anyone with a new diagnosis of spontaneous seizures, especially if they're focal or if the person is an adult. MRI is usually preferred.
Why MRI over CT?
MRI, particularly using an epilepsy protocol with specific sequences, gives much better detail of brain structure and can pick up subtle abnormalities that might be causing the seizures, like small scars or developmental issues that a CT scan might miss. CT is more for emergencies, looking quickly for bleeds, major strokes, fractures.
So MRI is the go-to for looking for underlying structural causes.
Generally, yes,
Yeah.
though there might be exceptions, like maybe a child with very clear features of specific idiopathic generalized epilepsy and a classic EEG, where imaging might not be immediately essential. But for most new adult onset epilepsy or focal epilepsy, an MRI is standard.
Okay, so the core message seems to be diagnosis is clinical first, based on the stories supported by EEG and neuroimaging, especially MRI, to build a complete picture.
That sums it up perfectly. Clinical diagnosis, EEG is supportive, MRI is often recommended to look for a cause, especially in adults or with focal features.
This has been incredibly thorough. Thanks so much for walking us through that complex landscape. To wrap things up, can you just quickly recap the main takeaways for everyone listening?
Sure. So the current standard is the 2017 ILE classification. Remember the three tiers: seizure type first, focal, generalized, unknown, then epilepsy type, focal, generalized, combined, unknown, and where possible, identifying a specific epilepsy syndrome. Always consider the underlying cause, the etiology, structural, genetic, infectious, metabolic, immunologic, or unknown. And diagnosis relies heavily on clinical assessment, supported by EEG and neuroimaging like MRI.
And why does getting this classification and diagnosis right matter so much?
It's absolutely crucial. Getting it right guides treatment decisions, which is fundamental for improving quality of life. It helps predict the likely course of the condition, and importantly, helps manage risks like seizure-related injuries or the rare but serious risk of sudden unexpected death in epilepsy. Accurate diagnosis is the foundation for effective management.
Makes perfect sense. And you mentioned a resource earlier for people who want to learn even more.
Yes, the ILAE has a really useful website, epilepsydiagnosis.org. It's designed more for professionals, but has great information and videos explaining seizure types, epilepsy types, syndromes, etiologies. A very valuable resource.
Excellent. Epilepsydiagnosis.org. We'll make sure that's accessible. Okay, finally, after exploring all this detail, what's a final thought you'd like to leave us mulling over?
Well, diving into this classification really shows just how much nuance there is in epilepsy, doesn't it? It's not monolithic. So maybe the thought to ponder is this. Now that you have a deeper appreciation for how varied seizures and epilepsies can be and how they're categorized, how might that understanding change the way you perceive or interact with or even support individuals living with epilepsy in your own life or community?